Good morning. I want to first thank the members of the Planning Committee who helped to put together this workshop, and the committee included roundtable members like Terry Allen, Martin Sepulveda, Jim Nickman, Phyllis Meadows, and we were also aided by others from outside the roundtable, including Dawn Alley, Maurice Ash, and Aaron Wernham. And a list that has their bios is also in that book that you have with you. Now, today's workshop is really meant to be a meeting of the minds, a dialogue between people who are dedicated to population health improvement and representatives from those sectors that George mentioned: housing, transportation, environmental protection, planning, education, and defense. And the starting point for those of us so committed to population health improvement is that we have much to learn from our colleagues in these other sectors about how best to collaborate with them to incorporate considerations of the health implications of their policies, programs, and projects that do not have health as their major end goal. So this morning we're going to hear about successful interagency collaborations at the federal, state, big city, and local level from speakers representing those sectors. The United States has been slower to really address intersectoral engagement for health than other countries, including England, Australia, Canada, the Northern Europeans, or the World Health Organization. But the good news is that when the Planning Committee turned to look for these examples, the number of these collaborations has grown exponentially in the United States over the past 10 years. They can be found from Massachusetts to Memphis, or from Akron to Alaska. But at the same time, they're still more like points of light than they are like a nationwide way of doing business. And that's our challenge. This afternoon, we will hear about approaches to facilitating the inclusion of health considerations through increased use of tools such as health impact assessments, community benefit partnerships, establishment of interagency relationships backed up by legislation and even funding, and the potential of combining the goals of health with other goals, such as sustainability or a healthier economy. Now, I'm going to give you some help on George's charge and suggest 4 questions or themes that you might want to keep in mind during the day. First, as I mentioned, you're going to hear experiences from across the local to regional to state, federal spectrum. Is it possible that some approaches, some policy areas, may be easier to move forward at different levels? Consider, for example, in how many states tobacco bans started in local communities and bubbled up to the state level. Is there an analogy in incorporating a health lens into policy making? Second, what are the challenges agencies and organizations have faced in incorporating health considerations into their policies and programs? Are there best practices for a health-oriented agency or organization to approach, message, language, and support other agencies in bringing a health lens to bear on their decisions? How have co-benefits or win-win outcomes been achieved? And several of the papers in your background materials have excellent articulations of both the challenges and potential solutions, including Rigby's Health Affairs article on the National Prevention Council, or Bostic et al.'s Health Affairs article on the Housing and Urban Development Department and Health and All Policies, or the Rudolph et al. Discussion paper on the California Task Force for Health Improvement. Third question for you: what are the pros and cons of focusing singly on incorporating health implications as compared to combining the incorporation of health and equity implications? Or, as with the California Health and All Policies Task Force, combining health, equity, and sustainability? Or alternatively, health and economic goals? It raises the question of whether the union of goals will be more likely to improve population health and reduce disparities because they have the potential to address the upstream causes leading to inequitable opportunities for health. And it's notable when you look back that, for example, the Sustainable Community Partnership, which combined HUD and the Department of Transportation and the Environmental Protection Agency around synergistic goals of creating livable communities with affordable housing, reduced environmental hazards, which in turn should lead to improved employment opportunities and economic vitality in a community. They rarely stated improving health as a goal, even though they're actions that all population health people would see as promoting health. A fourth concept to ponder today concerns the imbalance of attention to date along the entire policy spectrum, from the physical or built environment to social and economic policies. And the lion's share of intersectoral assessment and intersectoral collaboration and assessment of health implications has been on the physical determinants of health. Perhaps because the effects of the physical environment are tangible. It's easier to understand the connections between those elements and health. It may be harder for people to understand the pathways by which social and economic policies affect health, or more politically challenging, even though the social and economic environmental policies may have much more powerful effects on health. And there are copies of a breaking discussion paper for the roundtable outside that focus on inclusion of economic policies. But now to turn to social policies, I'm going to introduce our keynote speaker, Dr. David Williams, who will address how social policies shape health and the evidence and the opportunities. Dr. Williams is a Florence Sprague Norman and Laura Smart Norman Professor of Public Health at the Harvard School of Public Health, and also a professor of African and African American Studies and of Sociology at Harvard. He is internationally recognized as a leading social scientist focused on social influences on health. His research has enhanced our understanding of the complex ways in which race, racial discrimination, socioeconomic status, and religious involvement can affect physical and mental health. And he's the author of over 250 scholarly papers in scientific journals. He has served and led multiple committees, including 7 committees for the Institute of Medicine, the MacArthur Foundation's Research Network on Socioeconomic Status and Health, and he currently directs the Commission to Build a Healthier America. Dr. Williams spoke during the first session of the Population Health Roundtable last spring, and if you're interested, all of the Roundtable's workshop sessions are archived on video on the IOM website. But his contribution was so profound that we asked him to return to address social policies today, which he graciously accepted, despite his trip out of the country later today. Thank you, David.